going to be talking about the right ventricle and the pericardium in regards to assessment using FICE. The objectives of this talk are to run through the FICE views and with particular focus on the right ventricle. We're going to focus on the assessment of the right ventricle and I'm going to show you what normal looks like and give you some pathological states for you to compare it against. And the same goes for the pericardium. It won't surprise you to know that the right ventricle and the pericardium can be assessed in every view that FICE teaches, and that includes the parasternal long axis, the parasternal short axis, the apical forechamber, the subcostal forechamber, and the IVC assessment is also important when assessing the right ventricle and the pericardium. Now, the difficulty with the right ventricle is its shape, and it's very odd. It's this odd triangular crescent shape that's very, very difficult to depict well with any 2D imaging technique, such as echocardiography, for instance. You can underrepresent its size and misjudge its shape depending on how you slice it. So actually, it's very important that you collect all the views before you make your judgment on its size and its function, more so perhaps than any other structure in the heart. The parasternal long axis is the first view you get, and the right ventricle features here at the top of the image, nearest your probe. It's separated from the left ventricle by the interventricular septum here, and just so you get a reminder, the aortic valve features here, mitral valve here, and left atrium here. The descending aorta, which is here, is an important structure as well. Any pericardial fluid that collects separates out the pericardium from the myocardium and actually displaces the descending aorta away from the heart. Pleural fluid, on the other hand, will push the descending aorta in towards the heart, and that's one way to differentiate the two. The right ventricle shouldn't really take up more than a third of the whole width of the heart in this view. So this being a third, this being a third, and this being a third. And overall, if you measure the right ventricle, it shouldn't be more than 2 centimeters in this view. The parasternal short axis mainly focuses on the left ventricle. You may see the right ventricle wrapping around it in a crescent shape as such, but you very rarely see it all. And you very rarely see the free wall. The important information here is the shape and functioning of the interventricular septum. So, seen here. Now, the interventricular septum acts as part of the left ventricle, and it should appear like any other wall of the left ventricle, coming in towards the center of the left ventricle during systole. Now, that is because the pressure in the right ventricle at any point throughout the cardiac cycle is lower than the pressure in the left ventricle. If pressure rises within the right ventricle, so it's greater than the left ventricle, the septum actually starts flattening out into the left ventricle, and it forms a D shape, and you'll see that in some subsequent slides. The apical forechamber is perhaps the most useful view to get an idea of how big the right ventricle is and its systolic function. You don't always get a great view, as perhaps in this case. You don't always see the free wall, which in this case you can't really visualize it. But the idea is that you look at how the right ventricle appears next to the left. It's important that you make every effort to get a good image and make sure you haven't foreshortened the heart. So to falsely identify that the right ventricle is forming part of the cardiac apex, which of course in health it doesn't. So if you foreshorten the heart though, it may appear that this is the case. This is the left ventricle and this is the right ventricle. You can see that in this case, the right ventricle appears to be dilated because it's almost the same width as the left ventricle. It should normally be around a third of the whole cardiac diameter, with the left ventricle forming 2/3 of the cardiac diameter. In this case, it appears to be nearly 50-50, which makes it moderately dilated. If it's bigger than the left ventricle, it'll be severely dilated. You can eyeball its systolic function by looking at this structure, which is the tricuspid valve annulus and annular plane. You can see during systole how the annulus moves towards the right ventricular apex. Now, this is obviously a normal systolic function, so it's moving clearly more than 2 centimeters in towards the right ventricular apex during systole. The cutoff is 14 millimeters, some books say 16 millimeters, and anything less than that is considered abnormal. You eyeball the free wall movement as well, if you can see it, and that should come in towards the septum. If it doesn't, that would imply there is reduced systolic function of the right ventricle. Both these aspects are reduced, the shortening of the right ventricle and the free wall motion of the right ventricle, then the right ventricle is likely to be severely reduced in its systolic function. Moving on to the subcostal 4-chamber view, this is the kind of view you get, sometimes better, sometimes worse, and in many ways it doesn't add a lot to the other views because it doesn't accurately represent the right ventricle size or shape very well, because it really depends how you slice the right ventricle with your beam. What it does do, however, is allow you to gather information on 2 important aspects. The first being the pericardium. The liver forms a lovely acoustic window, and if there is any pericardial fluid, it will appear very, very clearly just here. Here you can make a measurement of how big it is. This is one of the best views to make that judgment. The second thing that's very useful for is to look at the right ventricular free wall thickness. This is it right here. Because the right ventricular free wall is perpendicular to the ultrasound beam, it's imaged very well. And therefore you can have a look at the right ventricle to see if it's thick. If it's thick, it implies the right ventricle has been exposed to a chronic afterload problem, such as pulmonary hypertension. And therefore there is a chronic disease process affecting the right ventricle going on. The normal width is around ½ centimeter, so anything greater than this at the end of diastole would imply a right ventricular hypertrophy state. Looking at the IVC is really important, and I'll talk about that later and what that means, but it gives you some information of right atrial pressure and therefore right ventricular filling pressure. And if there's disease of the right ventricle, this is likely to be elevated, the right atrial pressure is likely to be elevated, and therefore the IVC becomes dilated. So let's talk about the right heart. We're going to talk about the size, and that should include the cavity and the wall, the shape, and its function. So, as I said, it normally composes around 1/3 of the entire width of the heart in the apical 4-chamber view, and that's the normal state. If it dilates up to being around the same size as the left ventricle, that's moderately dilated. If it's greater than this, it's described as severely dilated. Obviously, there's some caveats to that. If the left ventricle is severely dilated, then the right ventricle being the same size as the left ventricle would also imply it's severely dilated. So you just got to use your common sense. But that's a general rule of thumb. Generally, if you were to make a measurement, the base of the right ventricle measured below the tricuspid valve shouldn't be more than 3.5 centimeters at the end of diastole. But obviously FICE doesn't teach any specific measurements in this way. And also looking at the heart as a whole, the left ventricle should form the apex, not the right ventricle. So if you're sure that you haven't foreshortened your heart, if the right ventricle encroaches into the apex or takes it over completely, then there is likely to be very, very significant dilation of that right ventricle. Function, we teach you to eyeball the right heart function. The first thing to say is the tricuspid valve moves towards the right ventricular apex during systole. The whole right ventricle shortens, that's how it ejects. This forms the vast majority of its systolic function. By eyeballing this movement, you can tell whether it's relatively normal or not. If you were to measure it, anything less than 14 millimeters is almost certainly abnormal. Radial function, when imaging, refers to how the free wall moves in towards the septum. Now, this forms a less important part of overall right ventricular systolic activity, but it's still important. And if the free wall is fixed and dilated and not moving at all, that would imply a reduced systolic function of the right ventricle. You put these two features together and you come up with an overall assessment. And you've got to look for other things as well. Is the RV wall thickened? And if it is, it implies there's chronic disease going on. Is the intraventricular septum moving in a strange way? Is it flattening during diastole or flattening during systole? Is the right atrium dilated, which would imply right ventricular filling pressure is elevated, so that would imply a degree of right ventricular heart failure. A dilated IVC, given that the IVC fills the right atrium, would imply the same thing as well. So the other things to look at when assessing the right ventricle is the right atrium, its size, and looking at the intraatrial septum to see whether it's deviated into the left or not, which would imply very high right atrial pressures. Looking at the tricuspid valve and seeing if it grossly looks normal. Looking at the IVC, which I'll talk about in a minute, and looking at the pericardium, any pericardial fluid, and any signs of pathology. Now, this study from 25 years ago was done in echo labs in well-ish people, so it doesn't really have much application to the intensive care patient. And often we are lucky enough to measure the CVP directly with a CVP catheter. If you don't have that luxury, then you can make some assessment of what the right atrial pressure is by looking at the IVC. If it's less than 2 centimeters and collapsing during inspiration by more than 50%, the CVP is likely to be normal, between 0 and 5. If the IVC is greater than 2 centimeters and is not really collapsing by this degree, then the CVP is likely to be quite high, certainly above 10. So you can guess what the CVP is by assessing the IVC. I have to make a cautionary note here that the ITU patient is way more complicated than the well patient that's just walked into echo lab for a routine echo. So the likelihood of this being accurate in intensive care is very minimal. However, there have been specific studies in ITU, and overall you can kind of make this generalization, but again this needs to be taken with a pinch of salt. A very small IVC, less than 1 centimeter, would imply that the patient has a very low right atrial pressure and is almost certainly fluid responsive. A patient with a very big IVC, greater than 2 centimeters, the chances are they have a high CVP, right atrial pressure, and they are likely to be fluid unresponsive. Now, in between 1 and 2 centimeters, there's a bit of a grey zone, and you can look at its collapsibility if the patient is spontaneously breathing, or its distensibility if the patient is mechanically breathing, as a guide. The more it collapses or distends, the greater the chance the patient will be fluid responsive. But it really is a bit of a grey area, and it needs to be taken in context of the rest of the scan and the rest of your patient. So let's look at the right heart when it goes horribly wrong. Now, if you think back to the previous slides where we've looked at normal, here you can see the right ventricle is taking up way greater than 1/3 of the whole cardiac width in this view. So it's very prominent. It's definitely greater than 2 centimeters. And actually, quite disturbingly, the left ventricle looks pretty squished. So the right ventricle here is actually causing septal deviation into the left ventricle. And if you were looking at the left ventricle in isolation, you would say it looks hypovolemic. However, a dilated RV means giving fluid is actually a relatively dangerous thing to do. You could actually worsen the RV dilatation, which in turn would worsen the squishing of the left ventricle. So, pretty difficult thing to manage. Again, if you look at the short axis, you can see that the right ventricle looks very, very prominent here. You don't see the free wall, but you get the impression the right ventricle is very, very dilated. You see the intraventricular septum looks abnormal. It's moving abnormally. And during systole, when the ventricle is contracting, it flattens. And this is the D-shaped ventricle. If the flattening occurs during systole, it's an acute pressure overloaded system. So classically this occurs with PE, but you can also induce it with a very good ventilator recruitment maneuver and other pathologies as well. This is the apical forechamber, and you can quite clearly see that the right ventricle is bigger. So this would be a massively dilated RV. You can also see that the apex of this heart is made up of both the right ventricle and the left ventricle. So that's an abnormal state. Now, when talking about the systolic function of this right ventricle, you may be tempted to say, it looks all right. Clearly, the tricuspid valve is bopping up and down, and there's clearly some movement. But I would argue that that's not the case. First of all, the first thing to say is that the free wall of the right ventricle, seen here, doesn't seem to move very much. So that is pushed out and paralysed out and is not contributing to any systolic activity as well. And the tricuspid valve does appear to be moving, but actually, I would argue that it's the left ventricle that's pulling it along and changing its angle. So if you focus in on the cavity of the right ventricle, it doesn't seem to be changing at all during systole and diastole, or very, very little. So overall, this ventricle is severely dilated with severely reduced systolic function. The IVC in this case is pretty fixed, not collapsing, and is in this case nearly 2 centimeters. So that would imply a high right atrial pressure, or CVP, and a fluid unresponsive state. And indeed, you would not want to give this patient fluid for the reasons mentioned before. And of course, this is an acute PE, so you have a dilated and impaired right ventricle, D-shaped flattening of the septum, particularly during systole if it's a PE, because it's a pressure overloaded system. You may see a clot in the right atrium, the right ventricle, and again, you've got to remember that there is a differential diagnosis for acute right ventricular failure, PE being one of them. It is the one that we teach you to identify within a FICE scan, but there is a differential. You've got to not forget your clinical medicine. And here is the clot floating around the right atrium. Let's move on to pericardial effusions. When you see a pericardial effusion, you can describe it as there's not one there, or just a trivial amount. You can describe it as small, or you can describe it as needing to trigger an urgent cardiological assessment and a formal echo. And overall, what would count as trivial is less than 0.5 centimeters. Small would be 0.5 to 1 centimeter. A moderate amount would be 1 to 2 centimeters. And anything greater than 2 centimeters would be considered large and would be potentially a medical emergency. I would advise you to get an urgent cardiological opinion if you see a pericardial effusion that's greater than 1 centimeter. This is what it looks like. So this is a parasternal long axis view. You can see the heart very nicely there, and you can see this fluid that has separated out the pericardium from the myocardium. The descending aorta here is pushed away from the heart. The fluid comes between the descending aorta and the heart. So this identifies this as pericardial rather than pleural. And you can see it's circumferential. There's clearly some fluid here as well around the right ventricle. In the parasternal long axis, again, you can see the circumferential nature of the pericardial collection. And in the apical forechamber, it becomes apparent once again. Now, you can see how in the previous 3 images, you may think, it's actually not that big. But when you come to the subcostal view, which is the best view for assessing pericardial collections, you can see that it's actually chuffing ginormous. And that's because, obviously, fluid, if it hasn't clotted, collects inferiorly. And the subcostal viewing looks at this particular angle very well. So this fluid is all collecting inferiorly, but the fact that it's circumferential, more anteriorly and superiorly, implies it's large. So, and there's some very worrying features about this scan as well. You can see how the right ventricular free wall is moving around like a trampoline. Same with the right atrial free wall. And the right ventricle and the right atrium look very small. So there's clearly some impaired filling of the cavities going on. You can see how the whole heart itself is moving around in this bag of fluid. And that's what causes electrical alternans, which is an ECG feature you may have learnt about in medical school. These are two further examples. So this, again, is a pericardial collection. You can see that the right ventricle is clearly being affected because the right ventricular free wall movement is exaggerated. And here the fluid comes in between the descending aorta and the heart, identifying it as pericardial. Here, it's not so clear that this is the descending aorta and this is a pleural effusion that you see here. So the important thing to say about tamponade is that it's a clinical diagnosis. If you see pericardial fluid and the patient is shocked, you've got to take it very seriously as a causative factor for that shock. So hemodynamic compromise is suggested on echo if you see the right atrial collapsing, if you see the right ventricle collapsing, and if the IVC is dilated and doesn't vary with respiration. And that implies that the pressure on the right side of the heart exerted by the pericardium is so great that it's preventing filling. So the venous blood is backing up. The IVC is therefore dilated. If these things aren't there, it doesn't mean that your pericardial collection isn't causing tamponade. So it remains a clinical diagnosis. This patient, without telling you any clinical features, should raise alarm bells. You can see the pericardial collection appears very, very large indeed. And if you look at the right ventricular free wall, it looks like it really is being heavily impacted by the external pressure of the pericardial fluid. That impacts its filling, and therefore the cardiac output is markedly reduced in this case. You can see the same here. The heart is swinging around in this big bag of fluid. The right atrial wall in particular is being compressed, and therefore there's no filling of these cavities whatsoever, therefore no blood being passed onto the left ventricle, and therefore the cardiac output is very, very compromised. The IVC in this case is fixed and dilated, implying impaired right-sided filling. So if you see this kind of thing, the diagnosis is easy, the management decisions are easy. This is a very straightforward cause of shock, which is very easily managed. So that is the end of the talk for this module. We've talked about the FICE views and how to assess the right ventricle, its size, its shape, its function, and the pericardium. And we've looked at some disease states as well. Now, if you're watching this online and you want the credit for watching the module towards your modular FICE GETIT accreditation, please point your phone towards this QR code or go to this website, complete the questions. You need to get 5 out of 6 right, and then follow the instructions on your phone to save a copy of your certificate. Show us at one of the Tuesday sessions to get your signature. I hope this has been useful. Bye.